Thank you, Dean Rashad. So we'll now go into our agenda. And so as part of the agenda, we have the program committee identified several individuals who have really made immense contributions to the field of brain health equity. And we had so many people to consider, but for this inaugural meeting, 5 individuals rose to the fore, and we are going to be hearing from them later on. But the very first is Dr. Bob Adams, who is, of course, here at MUSC and has been a phenomenal mentor and friend and colleague to me. But for the purposes of this introduction, I will go over a few of his many accomplishments. So Bob is now Professor Emeritus, Distinguished University Professor Emeritus here at MUSC. He's the co-director of the South Carolina Alzheimer's Network. He's also president of Xeriscope as well, which has been on the cutting edge of exploring devices to try and improve healthcare. Of note, again, he has so many accomplishments, but he was chair of the American Heart Association Stroke Council. He did receive the presidential lectureship of the American Academy of Neurology. He also received the Award of Meritorious Achievement from the American Heart Association and also received the Sherman Award from the International Stroke Conference in 2013. Bob has made so many different contributions, but high up there are his contributions in terms of sickle cell disease, really in terms of trying to validate that transcranial Doppler can detect children who are at high risk for developing strokes. And then, of course, the pivotal STOP trials, STOP 1 and STOP 2, both of which looked at the administration of red cell transfusion in order to reduce the risk of strokes. And I suspect Bob will talk about some of that as well. But as if that wasn't enough, Bob also was involved in really trying to transforming stroke care in South Carolina. He was one that established the REACH MUSC Stroke Network, which was the first hub in a statewide telemedicine network. Started off with just a few, and they're now up to 39 different spokes in the network. And as you can see there, prior to the implementation of telestroke, just 38% of South Carolina residents lived within 60 minutes of expert care compared to 100% in 2023. And so truly honored to invite my friend, my colleague, my mentor, Dr. Bob Adams, to give us a talk entitled 3 Swings and 50 Years, an engineer takes aim at some of life's inequities. Bob? See here. Looking for your presentation. Thank you. Thank you.
Bruce, thank you so much. I am honored to be giving this, and also I have to say that I've learned a lot from Bruce. Really, it's not true that you quit learning after the age of 50 or 60 or 70. I think you learn things differently. You call them by different names, and ultimately, as you get closer to the end of life, you realize that we all become philosophers. So we're all philosophers towards the end. So when did I leave the thinking of an engineer and think like a physician? Well, probably never. An engineer is a problem solver, and that was brought out and maybe brought out in some of the discussions today, that I look for problems to solve. And it's not so much that I'm interested in a particular product, but I am interested in the process of solving problems that improve the product. So those of you that know me know that in the last few years, this expression of process and product and that dichotomy, they've sort of crept into my vocabulary as I think a little bit about process and product and how that can come about, bringing about different decisions that we make. So long story short, in 1973, I was not happy with how my life was going, even though I had a good job with AT&T as an engineer in a management development, which is a code word for a good salary. That means you're going to probably be in management and be one of these people that gets paid more than regular hardworking engineers. So I thought that was all nice and good, but then I thought, and the reasons why I thought this way are not important, but I came home one day and I says, when I'm 50 years old, what am I going to feel better about? Running the telephone company in Missouri or all over the Midwest, or doing something that would really help out mankind or people who are suffering? And this goes along with, of course, being in the seminary early in my life, which Bruce didn't mention, but then I thought about that as well. And I thought, well, that's easy. It's going to be doing something in medical research. And so by the time I was about 49, I did find myself at a hotel in Washington in and at a news conference, and next to me was a family with sickle cell disease and a child. These are the parents, and on the other side was Claude L'Enfant, who knows who Claude L'Enfant is or was. Yeah, there's Dan does. He was the director of NHLBI, and I don't know if he's still with us. I don't know, but at any rate, very nice person. And when they stopped studying the stroke prevention trial in sickle cell disease, when it came, when it had a positive result, he said, we're going to tell the world about it. They don't do that so much anymore, but he said, no, we've invested in this. People have invested in this done this hard work. We're going to tell them about it. Okay. My disclosures. This has been called the first molecular disease. I could talk a long time about sickle cell disease, but really I don't have the time for that. I just need to say a couple of things about it. And I'll say that it's taught medicine a lot as the so-called first molecular disease. And it was described by someone named John Herrick, described in the Western literature. It had been known about in medicine in sub-Saharan Africa for many hundreds of years, in part because its relationship as a protective element against certain infections, malaria principally. But he reported these peculiar elongated cells in Chicago in a Grenadian dental student, sorry. And he then went on the next year and reported myocardial infarction. And he did not remain a student of sickle cell disease. He reported it as a phenomenon in these peculiar cells. And as you can imagine, these cells do not traverse the circulation very well. So we don't want to have these cells because they don't do a good job of transferring, of carrying and then transferring oxygen to the tissues. So it's associated then with accelerated red blood cell loss and a bad intravascular hemolytic anemia. It's well understood from a genetics point of view, and it produces painful episodes, organ infarctions, and from the point of view of the nervous system, it's primarily affected in two ways. One, during development, these individuals, these children have to develop their brain in an environment where the hemoglobin carrying capacity is very low, and that can't be good, even though it's not been studied very much, but that can't be good. And then secondly, because of vascular disease, which is what I began to work on, they have brain infarction. There was a person named Virgil Seidenstricker, and there's a wing in Augusta named the Seidenstricker Wing that is named after him. He reported a case of sickle cell disease and hemiplegia and fatal brain infarction. And that's one of the first cases of stroke in sickle cell disease. But it was reported off and on here and there. And then Lou Rowland, who some of you know, if you know the history of the leaders in neurology, he wrote about this probably when he was a fellow or resident at Columbia. And it became on, it slowly came on the radar screen until by the time that I was a senior resident in 1984, a woman named Marie Russell had reported from Children's Hospital of Philadelphia a big angiographic series that showed that these kids who had stroke had intracranial narrowing of the circle of Willis arteries. And it was called vasculopathy. Wasn't clear why a microvascular process like sickle cell disease would cause a macro vasculopathy, but there it is. That's what happened. And that's what we were working with. Now, my involvement started with an 8-year-old young lady in Augusta who was seen in that clinic who had a minor stroke in 1984. And then a couple of years later, and I'm not sure exactly the time, but a couple of years later, the hematologist who became a colleague of mine working in this stopped the transfusions because we didn't know what to do. And then shortly after that, Renee had this gigantic infarction involving a large part of the left hemisphere. So incredibly, even though she was already 8 or 10 years old, she did end up recovering. She did end up, the last time I saw her, she was in her 20s speaking with on a cell phone, believe it or not. And I thought Roca had long since decided they couldn't move at that age, but somehow she was able to speak and did recover. And Virgil Mackey was in South Georgia hunting ducks with my boss, Tom Swift, who's an American Academy of Neurology former president. And Virgil said to Tom, "Don't you have somebody who needs a project? Why are these children having stroke?" Literally, this is how it happened. Tom talks to me. I said, "Well, I just got out of residency. I need something to do." So I added it to a list of 2 other things and began to work on this problem. And at the time, in 1985, we knew what was the cause, but at least we knew that the strokes were associated with large vessel vasculopathy. We didn't know why they were being developed, but at the same time, for a different reason entirely, somebody named Rooney Oslett had developed a transcranial Doppler for use in the ICUs. And he developed these for the neurosurgeons. He had never heard of sickle cell disease. And I met him by a happy accident, serendipity, lots of happy accidents that occurred during this project over the years. And he said, "I don't know anything about sickle cell disease, but I think that it might work." I says, "I want to know, will it detect narrowing of these vessels?" And he said, "I don't know why it wouldn't. Why don't you give it a try?" He was trying to diagnose post-subarachnoid hemorrhage vasospasm. Had nothing to do with sickle cell disease. But this is from one of his books. It's the Doppler and the Doppler waveform. So here's the question: could we develop a primary prevention strategy? We already had a way to prevent second strokes. Second strokes are after they've had an initial stroke, put them on transfusion every 3 weeks. We could prevent subsequent strokes. The problem is the first stroke might be might be severe, might even be fatal. So primary prevention is inherently limited unless the warning shot, if you will, is always benign. And in stroke, it's not always benign. Sometimes it's even fatal. So we needed a good marker. We knew about the stroke rates. I'm skipping lots of other data, but we knew about the stroke rates. And you could ask yourself, well, why don't we just transfuse all the kids? Let's just get them all in there and transfuse them all once a month, and we'll take care of the problem. Well, the problem is the number needed to transfuse would be about 200. You'd have to transfuse about 200 patients a year to prevent one stroke, and that was not very efficient. So we needed a better way. We couldn't do a clinical trial with such a low event rate as that. It just wouldn't have been practical. Now, MRI was coming along. People did say, well, why don't we use MRI to predict the stroke? But MRI and TCD are a great way of looking at this, and we can tell stories about why one is good for one thing and the other is good for something else entirely. Long story short, MRI is not a screening test. It's simply not friendly to use. We had this Doppler machine and we put it in a van and went all over South Georgia. We would come back from a 3-day clinic exhausted. We had maybe TCDs on 50 kids, and we put these data in the bank and we watched it for who would have infarction. Now, here's where you get to be philosophical at my age. So if we could detect the large artery stenoses, would we have enough time to intervene? Would we have an intervention window? And this is, I came across a quotation by Einstein that God is subtle but not malicious, meaning that we might, if we were to take this step and find this way of detecting these arterial lesions, we might have an opportunity. Well, as it turned out, we were able to detect the large artery vasculopathy. Here's what it looks like in another arteriogram. And I think I've indicated with this. We had pretty good ideas about what caused this, and they had to do with adherence of abnormal cells to the vessel wall, starting and eventually producing high-grade stenosis. But let me just tell you that we don't know now any more what caused the stenosis than we did when I started the project in 1987. But we have reduced stroke by about 90%, this kind of stroke in about 90%. It turns out that you don't need to understand the process to defeat it if you've got the commitment to bring about the tools that can be applied. So it would be nice to know what caused this, but you don't need to, because all we had to do was get people to do transcranial Doppler, told them when it reaches a certain velocity, they can then they can put them on transfusion. This is based on the Bernoulli effect. Here's kind of an example of what it looks like from one of the papers. So we got the funding to do the STOP study because of the risk model, because of all those kids that we did in the back of the van. We published this paper in 1992, which was the first of 3 papers in the New England Journal, original data papers that laid out the story of here's how you use TCD to detect the risk, and I'll show you the other 2 in the next minute or so. This is what it looks like, the using the mean velocity. So in 1994, NHLBI funded STOP, and there were 14 sites that were included in the randomized clinical trial. And we randomized them to periodic blood transfusion or normal care, which meant occasional transfusion. And there were 11 strokes in the normal care and 1 in the transfusion group. And it was unacceptable to continue the trial. The trial was closed. We had the press conference. The families were called in and said, decide, do you want to be on transfusion or not? So now we are in 1998 with the second paper in the New England Journal. Here's what you have to do. Now, I thought we had done our job when we published the first one. I thought we had told people how to find the risk, and that would be enough. But it really isn't enough. We had to show them as neurologists, we had to show them what to do with the Doppler. And that's what we did. So I'm going to skip over this and go to the second trial, which was basically a trial to see whether you could take them off after 30 months if they'd been on transfusion for primary prevention. And long story short, the answer to that is that you cannot. You cannot safely do that. They will, in fact, 16 endpoints occurred all in the halt transfusion arm, and there were basically none in those that had continued on transfusion. So when we left the field here, we said, you've got to find another approach. And that's a different talk, the kinds of things that have been used since then. But we had essentially gotten the field to the point where primary prevention was practical. And this, the third paper, discontinuing and showing how it's not safe to discontinue. All right, now let me say this about the second swing. So what about this business of where do you live and how, and the unfairness of the access to care? We already were dealing with a population in sickle cell disease that had so many of life's burdens stacked against them. Instead of playing like normal children that are 8 years old, they were in clinic, they were continually being brought in for testing, or God forbid for tests for being transfused after they had already had a disabling stroke. So we knew we could do better, and in fact have been doing better on that. We also had a problem though with people who lived in rural areas, and we had developed, the field of stroke had developed a way to treat that stroke with thrombolytics, but we couldn't use it if people couldn't get in to be seen. So, and this is really a true story. In 1999, I had a fellow named Sung Lee, and I did my best to interest him in the sickle project, but he was not interested in that project because he was interested in the access to TPA issue. And in Augusta, we had all these people coming in. They did not get treated with TPA because they were outside their window. And he said, I think we can do better. He had a friend who was a little bit of an engineer. Anyway, he built the system that became known as REACH, that then helped us provide remote, on-the-spot measurement of their qualification for getting treated with TPA. And in the book by Dr. Reeves on the College of Medicine, the Bicentennial History, this is where we are credited with going from, and what he actually says is that 38%, I think that's what you said, 38% of residents lived within 60 minutes of expert stroke care when we started the telemedicine or telestroke project. And in 2023, Dr. Homestead, who took over the program from me 2014, has developed it beautifully and expanded it tremendously, that she reported to the Joint Commission that that number was now 100%. So people working with people, that's what you can do even today with the challenges that we have. Find a group of people who understand what it means if you say, I'm willing to settle for part of something rather than all of nothing. And all of nothing is what you end up with lots of times when you don't work effectively with other people. Now that's 3 swings. I've got more swings to go. Maybe we'll get a chance to talk about those, but I also have a time limit. So I want to say thank you for the honor of being here today and to talk about these projects, and also to participate in the other activities that we have today, and for being part of SEQUINS. Thank you again. Bruce, thank you.
Thank you so much, Bob, for that wonderful presentation. We have, yes, we do. Yeah, no, now please, if that's okay. So questions for Dr. Adams, Dr. Mogensen.
So, Bob, that was great. I always say that among all the stroke doctors in the world, you've saved more lives than anybody else. And so your contributions are just so meaningful. So thank you for that. My question is, when you put the TCD machine in the back of the car and drove around South Georgia, what was the reaction of the families that you spoke with?
It's a good question. You know, Louis, they pretty much accepted it, you know, as, I mean, their first question was, is it going to hurt? And of course it doesn't hurt. And then is there going to be a needle involved? There's not a needle. So you couldn't have made a better device, if you will, for us, for the field than the transcranial Doppler, because of its features and its complete safety. But they didn't understand it. As a matter of fact, the last grant that I've been part of, the display study, which has been led by a hematologist who's now at UAB, they did focus groups and they changed the name of it, partly for something you're getting at. You are definitely right in bringing up the question of, does the family understand what's happening here? Because they needed to understand what we were doing, and it wasn't just some other test. So they named it stroke prevention test. They got rid of this funky transcranial Doppler thing. So having the family understand it better really is important. I'm not sure that's part of what you were getting at, but anyway, thank you, and thank you for your comments.
That was a great talk. Thank you so much. I learned a lot about that sickle cell. And so my question about, you mentioned earlier that it would take 200 people, 200 children to detect one stroke. So with the reverse of being, if they're getting transfusions to prevent primary stroke, what's the risk if they're removed, right? How many of those children would be more likely to have a massive infarction?
Well, I'm not sure I know exactly how to answer the question. I will tell you, I had to rush over it, but in the STOP2 study, we were not dealing with the 200. We were dealing with the high risk group.
High risk, okay. That was Okay.
Yeah.
Yeah, sorry, I didn't pose that very well. I was trying to get a sense of whether or not it's more risky for those patients who may not be able to continue transfusions, right? So if they have low access to care and you run into that risk, do you just choose not to give transfusions because it might increase their risk later on if they have to stop?
It's a good thought. It has been mentioned as a possibility. We don't yet know about that. I mean, I think the one disclosure I have is for work with a company that is using what's called a small molecule approach. Does everybody know what is meant when someone says a small molecule approach? I mean, I didn't a year ago. So really what you've got in the world right now of pharmaceuticals, you've got two things. You've got small molecules, which you can usually take by mouth, and you've got biologicals, which are monoclonal antibodies typically. And then there's some things in between. But neurology is a lot of the new agents that we have in neurology are big biologicals. They have to be given parentally. And small molecules are cheaper, easier to use. And there are data that say that there are some small molecules that should be effective at preventing this hemolysis. Hemolysis is driving the whole thing. We don't really care that there's one amino acid that's been replaced by another one. It's meaningless as long as the red cells don't hemolyze. It does a perfectly good job of carrying oxygen around. So, there's a lot we could do. I love the work that's being done in gene therapy for sickle cell disease. Problem is, I'm too much of a public health person in a sense that the cost is so great that I'm just concerned that it's going to end up being nothing more than a demonstration project, and that we really need to apply very pragmatic tools, greatest good for the greatest number kind of thing. At any rate, thank you for your question.
One more question, anybody? Dr. Saylor.
Thank you so much, Dr. Adams, for that great talk. One of the things that I think is so wonderful about your work is the multidisciplinary collaborations, both within medicine and outside of medicine. What advice do you have for all of us as we think about how we can improve our own work by involving disciplines that aren't neurologists or even aren't physicians?
I'm sorry, I missed that. Bruce,
other disciplines into tackling some of these very thorny.
Yeah. Well, I think we make it more difficult than we have to. I think if we talk to families and if we talk to people that are involved, and we need to talk to primary care. So the first question is, who is the primary care team constituent for a child with sickle cell disease? Is it a primary care doctor? And actually, no, it's usually a regular hematologist who's not a specialist. And the way their world is structured is you got a pediatrician that may or may not be a hematologist, but is at least a pediatrician. And then the next level up is specialist pediatricians who are in a tertiary structure for that have pediatric hematologists on their team. And that, I think, is one of the things that we can do. I think if we take the time to talk to people and to have those people tell their stories, I think it will mean a lot. Like when we were at that hotel in 1997 in September, and we heard from the mother, then we heard from family members. I mean, I think they were very effective at telling the story about what the STOP study had meant. One of the most dramatic things that I ever heard about this work I got a call from somebody I didn't know who is a pediatric neurologist from Seattle. Seattle wasn't part of the STOP study. And she had a question about the cases. And she said, by the way, I just want you to know that we, and this is about 10 years after the STOP study. And she said that you wouldn't believe what it's like. We used to have these patients wheeled in by their parents with severe disabling stroke. Now they are bringing in their older siblings who were stricken pre-stop, but they are healthy, robust, whole, if you will, and they have the same sickle cell disease. They just came along after STOP, and we were able to pick them out and to keep them from being in that category. So that really was good. That made me feel good. What we're doing good.
Thanks so much, Bob. And as Lewis said, tremendous impact. And one of the questions I will ask you later is just how, because we have lots of African attendees online, is how this has translated to underserved regions around the world, even underserved places here, and the issue that Dr. Sankar mentioned about access as well and other things. But thank you so much for all you've done in terms of moving the needle and also for a wonderful talk. Thank you, Bob.